Thank you, Divya, for the nice introduction. And it's my pleasure talking to all the participants on this webinar. So I'll get started with sharing my screen. Divya, can you confirm if the screen is visible?
Yes, just maybe open on slideshow.
Yeah, is it on the slideshow now?
Yes, yes.
Okay, so I'll proceed. So I'll talk about the evolution IOLs, the materials, designs, some special IOLs. So the evolution of IOLs, the journey of the intraocular lenses started with this great gentleman, Sir Harold Ridley from UK. He was the first one to implant the IOL on 29th November 1949. We are almost very close to that date so many years ago. Okay, so the IOLs were first implanted and it has gone through a lot of evolution and changes. But before we get into IOLs, I think let's understand some common things about the intraocular lenses. So because this will be relevant as we go through the rest of the sessions. So anterior chamber, most of you would know, is the space here between the iris and the cornea, and the posterior chamber is behind the iris. And sulcus is the space between the lens and the iris, behind the iris and between the lens. And the capsular bag is the part of the natural crystalline lens, which is left behind after the cataractous lens is removed. And the iris, of course, we know. And how many of you have actually seen an intraocular lens, real intraocular lens? Divya, can we have a small poll on that?
You should be able to see the question on your screen.
Yes.
Right? Yes, if you've actually seen a
real intraocular lens.
Yeah. Please don't raise your hand. Please answer using the poll box. Okay, some of the answers are coming in. Just give it a few more seconds.
So is it mostly yes or mostly no?
Just share the... Okay. Are you able to see the results?
Yes, so mostly they have seen. Okay. So for the small proportion of people who have probably not seen, I don't know if you said visible. This is the intraocular lens. This is the size of the intraocular lens. Okay, this is what I'm holding is a PMMA intraocular lens. Okay, the haptic and the optics and the lens.
Just keep your thumb near it so we can see it for scale, how big it actually is.
Okay. So is it visible with my thumb and the lens? I think because I'm using the background, I think it's not very much seen. Yeah, so this is the thumb, this is without the thumb. Okay. So anyway, so the idea is that, it's very tiny that gets placed inside the eye. Okay. So in the lens, we actually have the central part of it, which magnifies and gives the refraction, and that's called the optic. And the haptics are the hand-like things that keeps the lens inside the bag in its place. Otherwise, it will keep floating around. So that's the purpose of these hands, that after implantation, it's sitting in one place. And we used to have these two holes on the intraocular lenses. Maybe some of the PMMA lenses still have it. It is called as dialing holes. These are used by the surgeons to put the lens in its place after implanting it. So these are the core parts of the intraocular lenses. And this is just a diagram to see the various, shapes of intraocular lenses in the past. Okay, you have seen the mobile phones evolving. The intraocular lenses have also evolved a lot through a lot of designs and shapes. And So we'll go to the materials now. So the materials have largely 4 to 5 types of material that, and the first intraocular lenses have actually come from the PMMA, or which is called as polymethyl methacrylate. This is the material that was used by Dr. Sir Harold Ridley. And this is also referred to as hard lens or rigid lens. This is because, it is basically like a plastic, it's hard, okay? And it's a plastic material, biocompatible plastic material. That's what sets this PMMA material different from any other material, okay? So on these lenses, you have basically two types of IOLs, which is called as AC IOL and a PC IOL. AC IOLs are the lenses that used to be placed in the anterior chamber of the lens. Okay, and these are typically used where PCIOLs cannot be used or in large cams, but this is a thing of the past. Now, nowadays, the ACIOL usage is much lesser. The PCIOLs are kept in the posterior chamber, and there are two types of PCIOLs, which is three-piece IOL and single-piece IOL. Three-piece IOLs are easy to train and learn. They are used in complex cases, and they're also used for sulcus fixation. But again, this is also a product that is almost on its way out. There are very few manufacturers who are still manufacturing this product. Single-piece lenses have become the norm for a very long period of time on the PMMA platform. They are the most preferred, and they can be implanted inside the bag. And they come in various optic sizes from 5 mm to 6.5 mm. The most commonly used is the 6 mm optics. So next is the hydrophilic foldable lenses, which is made from the material called hydroxyethyl methacrylate. So this is also a plastic polymer, and this is called as a foldable lens. Okay, so this lens is typically, it can be folded when it allows. I don't know if is this the lens visible? Yeah, see. The lens is actually, I have folded it between the forceps. Okay. So the foldable IOLs, that's the different. It allows the lens to be folded and put inside the eye. So basically, it allows the lens to be put through a smaller incision. The rigid IOLs needed a larger incision, and this foldable lenses can go through a smaller incision. And these lenses are called as hydrophilic foldable lenses. They are the same materials that are used in contact lenses also. These are commonly available materials, hence they have lower cost. They are manufactured in dry state. So one specialty about this hydrophilic lenses is it is foldable only when it is placed in water or when it is sufficiently hydrated. So these lenses can absorb the water and can become flexible. Okay, that's the specialty of this hydrophilic lenses. Because of its flexible nature, it can be inserted into the eye through smaller incisions. Okay, so they come in different haptic designs. They have something called as dual haptic designs. They give the benefit of quick recovery to the patients, and they are entry-level foldable lenses. The silicone foldable lenses, they are almost out of the market today. They came into the market. They are flexible at room temperature. But because of reactions to silicone oils, they have gone out of the market. So I'll not go much into this. The hydrophobic foldable lenses are the lenses of choice for most of the surgeons when it comes to foldable lenses. The reason is this is the first material that is especially made for intraocular use. Like I said, the hydrophilic material is also a biocompatible material, but that's a material that's already was being used in contact lenses and other purposes, which has been customized for use in intraocular lens implantation. But the benefits of a hydrophobic lenses, it is made for intraocular use. Okay. It is actually sticky at room temperature, usually between 30 to 35 degrees or that temperature, it is very sticky. That is why it is even more difficult to manufacture hydrophobic lenses. And hence you will find that the hydrophobic lenses are more costlier than the other PMMA and hydrophilic lenses. It is commonly referred to as acrylic lens, but even the PMMA, the hydrophilic, and the hydrophobic, they are all part of the acrylic family of plastic. Acrylic is basically a plastic family. So the advantage, why hydrophobic is better? Because it naturally prevents PCO. Because it has sticky in nature, it can stick to the capsular bag. The posterior capsular bag can stick better with the intraocular lens, and that will not allow the PCO formation. It has got better properties of in the back performance, and it has got good optical properties also. Now you have also come across yellow material lenses. Okay, these are normally found in hydrophobic material. It is theorized as a retinal protection because these lenses have an ability to filter a certain wavelength of blue light. Okay, and this wavelength of blue light is said to cause harm to the retina as the eye ages. Okay, so that is why this blue light filtering IOL or the yellow material IOL has gained popularity. It gives the replication of the natural lens, because our natural lens also, as it grows older, it becomes more yellowish in nature. Okay. Now, these are the common, between the PMMA hydrophilic and the hydrophobic lenses. These are the various factors in terms of flexibility, the differentiations, in what type of surgeries it is used, incision size. If you notice from PMMA, 5 to 7 mm. In hydrophilic lenses, it comes to 1.8 to 3 mm, and hydrophobic from 2.2 to 3.2 mm. So the PCOs are the least with the hydrophobic lenses. And if you see the applications, the hydrophobic lenses and the material is applied only for intraocular lenses, but the hydrophilic and the PMMA, they are used in multiple industries. Now let's get into, so I have covered the materials part of the IOLs. Now let's get into the IOL designs. Okay, so this is, some of these things have now become common. Some of the things are even talked of more now. Square edge design has nowadays has become very common. But I think I'll quickly touch upon what is a PCO, posterior capsule opacification. So after implanting the lens in the bag, usually, the cells migrate between the lens and the capsular bag, settle down, and they grow under this, okay, and between the lens and the capsular bag, thereby again clouding or stopping the light rays to pass through the lens and reach the retina. So sometimes this is also referred to as secondary cataract, and the common treatment option is the YAG capsulotomy. So, if you want to avoid this, you have to use a square-edged lens. Or if a better way to say it is, if you want to reduce the incidence of the PCO, then the square-edge design gives you a better probability of avoiding the PCO. Because this is not the only factor, there are other factors that affect the PCO. There's the surgeon factor, IOL design, and the capsular bending effect. So the characteristics of a good IOL design is that it should have sharp edges, it should have a 360-degree square edge, including the haptic optic junction, and it should have a rounded anterior surface. So a lens that has got all these properties, as I have shown here, on the posterior side, it should have the square edge. On the anterior side, it should have the round edge. And including at the haptic optic junction, it should have the square edge. So, if a lens conforms to this, then it's a good, square-edged intraocular lens. Yeah. So I'm moving on. It is difficult to make in the PMMA lenses, but more easier to make in the foldable lenses. So now most of the foldable lenses, they come with the square edge design. Yeah. So the next is the aspheric optics. The aspheric optics is something it's an improvement on the basic optic design of the lens. Okay, so in spherical, all the rays do not focus on a common point. Okay, usually when we see through a lens, we see the magnification, we think that all the lenses are focusing at one point, but it is not so. The rays from the corner of these lenses, they and the rays from the center of the lenses, they don't meet at the same place. So some of the clarity is lost in the aspheric optic. So to improve the visual outcome, you make the lens surface, not sphere, and thereby you achieve a common focus at all the points. So the benefit of a aspheric lens is that you get a better quality of the image. So that is the benefit of a aspheric lens. And that's what you will see, that some of the aspheric lenses are more costly than the plain monofocal lenses. Okay, so this is called as a zero aberration optic. So theoretically, a better IOL than the normal spherical IOL and expected to give a better contrast for patients. But I hope all of you know that its lens is not the main refractive surface from outside to the retina. It is the cornea, that plays the major role. Okay, so this negative aspheric optic takes into account the aberrations of the cornea. What is an aberration? Is that cornea is not a perfect sphere, and it has got irregularities like all people have. Cornea also has some irregularities, that is called, and most of the corneas are positively aberrated. So when we put a spherical IOL, then we are adding to the spherical, positive spherical aberration of the cornea. So the net result is a poorer, what you call as the outcome of the visual image. But with the negative spherical IOL, which is better than a zero spherical aberrated IOL, it compensates the positive spherical aberration of the cornea, which is the second, image at the bottom. And this lens and compensates the positive aberration of the cornea. The net result is a better, IOL when placed inside the eye. Okay, so this is the thing. A zero aberrated IOL is better than a negative aberrated IOL outside the lens. A zero aberrated lens, if I can say, and compared to a negative aberrated IOL, zero aberrated is better outside the eye. But when you put the inside the eye, taking into consideration the positive corneal aberration, a negative aspheric will give a much better vision to the patient, much better contrast sensitivity, and thereby the quality of the vision is better for the patient. These lenses are much more difficult to design, quality check, and process. So you'll find much lesser negative aspheric optic lenses in the market compared to zero aspheric optics. Next is the toric lenses. This is gaining popularity, and very rightly so, because toric IOL gives the opportunity for a surgeon and a counselor to correct the astigmatism if a patient is having. I'm sure most of you would know what astigmatism is. Very common way to know is like if they are wearing cylindrical power glasses, spectacles, when they come for cataract surgery, then we can assume that they have some amount of astigmatism. There are different ways of correcting the astigmatism. Most common is spectacles, contact lenses, LRA, but what is gaining ground is the toric IOLs. So on IOLs of this toric lenses, you will find some dots, 3 dots, okay? So on a spherical lens, only in that axis, toricity is introduced. So I think the way I'm explaining itself, you can understand that it is much more difficult to manufacture this optics of the lens, okay? So there is a third dimension which is involved when we are making this particular lens, and hence the cost is more, okay? And because I am sure you all know that each lens, the inventory is more. For each power, you have to make a lens. So with toric, the inventory holding is much higher, and there is a learning curve involved, a little bit for the surgeon and a little bit for the biometry team and the refraction team of the hospital also, because you have to take the K reading, and the company people generally help out with the selection of the right IOL for the patient. But the statistics is that almost 30% of the patients have cylindrical power, and they will benefit significantly with the use of toric IOLs, because there are good possibilities to get rid of the glasses after a surgery with the toric IOL, and that makes a hell of a lot of difference to the quality of life of the patient. This is one of the most talked of products more recently, and multifocals have been in the market for more than a decade. Okay, so a monofocal and a multifocal, very simply to understand, is this in the spectacles. The monofocal and the bifocal spectacles is very common, very commonly understood by everybody. We are creating a similar impact with the intraocular lenses. So I'm not going to go deep into the types of multifocal IOLs, because that debate is now more or less over. So multifocals is commonly referred. All you need to understand is, when a patient wants to see distance, with monofocal lenses, we commonly decide the lens power such that we give the vision to the patients at the distance, so that he can comfortably see the distance vision, because most of our day-to-day activities is at the distance. So we usually the lens is kept for distance visual acuity, but with multifocal lenses, it gives an opportunity to give good near vision also. So you don't have to look for spectacles to read something, or see the mobile phone or something like that. That's where the multifocal lenses gained popularity. Okay. Now, usually the range of seeing is divided into multifocal, that is the distance, intermediate, and near. I'll take 1 minute to explain that. Near is something that is typically 33 centimeters. That is the reading distance, is what generally considered as the near. Okay. Then intermediate is somewhere between 50 to 80 centimeters, typically where you keep your laptops, or a distance from your working distance with a computer, cooking and things like that. Okay, something beyond 100 centimeters is considered as a distance. So when typically you want to give the distance and near vision, you give them a multifocal lens. One thing you need to understand in this is that the amount of light entering the eye is the same. Okay. Well, how much of light coming into the eye, it remains the same. Whether if it is monofocal, all the light, the power of the light goes to one focal point. But with multifocal, the same energy is distributed into two focus. Okay. So we are compromising little bit somewhere to give a benefit in some other place. Okay. So that's the benefit of multifocal IOL. There are lenses in the market which is a trifocal lenses. That means which splits the same energy into distance, near, as well as intermediate. So that is called as the trifocal lens. Okay. Each of these lenses, they have their pluses and minuses. Okay. So these multifocal lenses, when you put, because you are distributing the energy between two focus, it can give rise to some photopic phenomena, something like glares and halos when sudden light comes, especially in night driving and things like that. But you have to understand that today the technologies have advanced significantly. And with the advancements in technology, the manufacturers are able to overcome many of these problems. Okay. And there is something called as extended depth of focus, or the EDOF lenses, that are becoming more popular today, because it takes away some of the disadvantages of the multifocal lenses. But what does the EDOF do is, it is extending the focus. It's literally stretching the focus. If the focus monofocal is 1 point, it is stretching to give it to something more. Okay. So if, as I said, if monofocals gives the distance at 100 centimeter, then a EDOF lens extends to up to, let's say, 80 centimeters or 70 centimeters, or something like that. There are different lenses in which they work differently. Okay, so this is the concept of the extended depth of focus lenses. So while extended depth of focus lenses can give distance and intermediate, most of them are not able to give a good near vision. But here's the catch. Okay, today, how many people are actually reading books at 33 centimeters? Okay, so if the lifestyle of the patient itself, if you understand that if it is available from 40 centimeters and above, or close to 50 centimeters and above, then there are lenses available in the market that meet these needs, the EDOF lenses that meets his needs. So, these are the things that are depending upon the patient's requirements, they need to be customized. Rest of the questions on this I'll address during the Q&A. And just for information, there are very many types of special IOLs. Scleral fixation lenses are there. These are kept when a lens cannot be placed in the bag. There are iris claw lenses that are placed in the sometimes in the using the iris, they are clipped on. Sulcus fixation lenses, these are the lenses that are placed between the iris and the bag. You have glued IOLs, aniridia IOLs, phakic IOLs. Phakic IOLs are something that, who have, it's basically a refractive IOL, it actually takes away the glasses. Accommodative IOLs, they came into the market, but today you don't have a very successful accommodative IOLs in the market. Telescopic IOLs, light adjusted IOLs, and electronic IOLs, these are some of the things of the future, which are yet to come. But, and just put it here so that, sometimes when this becomes a reality, you can say that, no, I have heard it somewhere. Okay, so these are the various specials, and IOLs is a very fast advancing field. So all these things, what I have put is just the last, more 30 years or so, 30 years, the IOLs have evolved so much. And in 30 years, we have been able to give so much better options to the patients for better quality of life. Okay. So now I'll move on to the next topic, which is the OVDs, or very short, very simply said, viscoelastics. Now, during the surgery, the viscoelastics play a very important role. Viscoelastics were first introduced in 1972 by Dr. Andre Ballas. And let me explain the term first, viscoelastic. Okay. So it is a combination of two words, viscosity and elasticity. So basically, viscosity, it's a measure of a fluid's resistance to flow. Okay. Like if you put water on a slope, then, it flows, very easily. I'll give you an example. I think that will may help you understand better. Elasticity, everybody understands. It's the ability of the object to regain its original form when an external pressure is removed. Okay, so that is when you apply pressure, it expands, and then when you release the pressure, then it takes its original form. That's basically the elasticity. So as I was giving the example, okay, so when compared to water and oil, I think you will agree that oil is more viscous. You understand now what I'm saying? What is the meaning of viscosity? Compared to an oil and a glue, you can say that, it is even more viscous. As probably a shampoo, you are more cream, much more, and a jelly, jelly and all, if you disturb it a little bit, then it will come back to its original shape and space. So that's the, examples of viscosity and elasticity. So viscoelasticity is the property of materials that exhibit both viscous and elastic characteristics when they undergo deformation. Okay. So what is an, let's move. So OVD is a ophthalmic viscosurgical device. This is like the official name, like, phacoemulsification surgery is the actual name. We commonly call it as phaco. So OVDs is the actual name. Ophthalmic viscosurgery device are transparent gel-like substances that have viscous and elastic properties, and they are used in ophthalmology during cataract, glaucoma, and corneal transplant surgeries. And the main functions, why do we use them, is that they help to maintain the space of the space for a surgeon is very, very important. When they go into the eye and they do so much work inside that eye through the 2 mm incision, all the space they have is between the cornea and the capsular bag. So by filling the space and pushing tissues aside, they make it easier for the surgeon to perform the procedure. Second thing is protecting the tissues is very important, because you're doing a lot of physical activities. With phaco, you're generating a lot of heat. So there are all the tissues inside the eye are very delicate tissues. So these viscosurgical device, they help give a sort of protection for these tissues. Lubrication. OVDs provide lubrication for the instruments used during the surgery by reducing the friction and minimize the risk of tissue damage while they are entering, exiting, and all those things. Okay. And they also play a role in controlling the intraocular pressure during the cataract surgery. So based on the chemical properties, there are three types: dispersive, cohesive, and a combination. Dispersive is this OVDs tends to become flat and they coat, so they give better protection to the tissues. Now the cohesive viscoelastics, they become like a lump, more like a jelly, okay, that I gave the example of. So these cohesive, they give better space, so. And then there is a combination viscoelastic, which is a mix and match of both these properties. So the surgeons use these OVDs from case to case. Okay. So one of the most commonly used viscoelastic in India and most of the developing world is the HPMC, hydroxy methyl cellulose. It's from a plant source, and it's the advantages. It is low cost when compared to the other viscoelastics available in the market. And the difficulty is that once you place it, this OVDs have to be removed. Okay, after that, the end of the surgery, they cannot be left like the intraocular lenses. We leave it inside the eye. These viscoelastics have to be completely removed from the eye. Otherwise, it will lead to increase in the intraocular pressure of the eye, rising of the IOP after the surgery. So there are basically three types of things. One is commonly called as the sodium hyaluronate, which used to be made from natural source, but today it is available through a fermented source. This is called the sodium hyaluronate. This is cohesive in nature. There are various percentages of it. I'm not going into this. And then there is something called as a chondroitin sulfate, which is a dispersive, which is coming from the shark fin, and a combined. So this combination viscoelastic is a combination of sodium hyaluronate and the chondroitin sulfate, which displays the properties of both being dispersive and being cohesive. So I'll quickly take you through the other surgical adjuncts. One is the capsular tension ring. Okay. So many a times when the surgeon wants to place the intraocular lenses inside the bag, the capsular bag is weak. Okay, there are the ciliary body. I mean which holds the bag in its place. So zonular ring. So those things, those zonules sometimes become weak, and they don't have the sufficient strength for the bag to hold the lens. So in that case, we use something called as the capsular tension ring, which is placed inside the capsular bag first before we put the intraocular lenses. So these cases are sometimes identified before going in for the surgery, or sometimes on the table only the doctor will need, and he will decide to use it. So this can increase the cost of the surgery for the patient by the cost of this device. So even in this, there are multiple types called a Sioni ring. It's a modification of this capsular tension ring. Another device that gets used during the cataract surgery typically is a pupil expander. Okay. Sometimes I think Balaji sir was also saying that the pupil doesn't expand to a necessary size even after administration of the dilatation drops. Then the only option is to mechanically make the pupil bigger. Okay. And there are a couple of options. One is the iris hooks, by which you make the pupil bigger, and then the surgeon does the surgery and then the hoops are removed. More recently, some more expanders are there, wherein once it is applied, then it expands the pupil in a circular fashion. So there are different things available in the market, but the purpose is this: if the patient's pupil doesn't dilate sufficiently, then the surgeon has to use an extra mechanical device to create the space for him to go in and do the surgery. Okay. So these are the things that I ran through to cover.